Thank you very much. I always feel we should have more time for. Anyway, this morning we have been talking about the role of, as the field of genetics is advancing and we're having more patients and less geneticists, and we have been discussing the role of a primary care provider. So I have somebody really brave here who is a member of American Academy of Pediatrics Committee on Genetics, and she's an assistant professor at the University of Michigan Medical School in the Department of Pediatrics and Communicable Diseases. I'm sorry, that's Dr. Beth Tarini. Her research focuses on the communication process and health outcomes associated with genetic testing in pediatrics. She's particularly interested in pediatric population-based screening programs, and through her research, she seeks to optimize communication about genetic testing between parents and providers in an effort to maximize health and minimize harm. I've heard her mention that several times. He has received several awards from the American Academy of Medical Colleges and Division of General Practices, including Outstanding Educator of the Year Award and Clinical Science Scholar. So please join me in welcoming Dr. Beth Tarini.
The slide is okay. Yep, fine. Thank you, Ronnie. It's my honor to be here today as the keynote speaker. I'm actually getting married a week from tomorrow, and I said I wouldn't do this talk if it weren't Ronnie who asked me. So, so I'm here to talk to you about the challenge of integrating genetics into primary care pediatrics and to equate it with, can we get the camel through the eye of the needle? So I have no conflicts of interest to disclose. So the question is this: how difficult is it to get genetics into primary care, or practice of genetic services into primary care? It's complicated. I once thought it was easy, then I thought it was very hard and impossible, and now I'm somewhere back in the middle again, given my experiences through the AAP and with newborn screening and the regional collaboratives. So this is where we want to get, right, to integrate genetics into primary care. The stethoscope is what at least the primary care docs carry around their neck as they traipse through the primary care clinics. May not tell us much anymore now that we have CT scans that we use, but it is the tool of the trade. So who am I and why am I talking to you, you might be asking? Well, I sort of have a split personality. On the one hand, I'm a general pediatrician. I see patients in clinic a day and a half a week. I see my own patients. I just don't supervise the residents. And the other part of the week, I'm a health services researcher who thinks about genetics. Why I think about genetics is an accident of history that we don't have time for now, but it deals with newborn screening and technology and being in the right place at the right time. And having a mentor down the hall like Wiley Burke, whose article you saw recently by Dr. Jansen posted. And because I was also in the right place at the right time, a second time, I was asked to be the co-medical director of the Genetics and Primary Care Institute, which is, or was, it's past May 31st now, a 3-year cooperative agreement between the American Academy of Pediatrics and HRSA, the Health Resources and Services Administration. Thank you, Joan. So first, I'm gonna go back to the GPCI and what we've learned, some of the things we've learned from it. But first I'm going to start off about what are the challenges. That was what the title was about. And these are based on my understanding of literature, my clinical experience and the research that we've done on my team, but we don't have time to present here, but I'm happy to talk with you about later. So the first challenge is belief. Belief, when I say belief, I mean belief about what is genetics. I think in primary care, especially in pediatrics for a number of reasons, our belief in primary care pediatrics about genetics is that we're not quite sure what it really means, and our definition of it or our reference point is rare disease. And we encountered this a lot in the GPCI. And that's not to say that rare disease is not a part of genetics. It's just to say when you're talking with primary care providers who do care for these children, I have some on my panel with rare inherited conditions, that is not the only place where they will see genetics, or if that is the only place that we talk about it, the relevance starts to sort of lose traction because they may or may not see themselves as providing genetic services to these patients. So this can become a problem when you're talking to primary care providers about why it's important to integrate genetics into their practice. It's sort of necessary but not sufficient. It's important, it should be included, but not sufficient. And the second challenge which comes from that is the so what, who cares? So as I said, I'm a primary care provider, day and a half a week I see patients. And when we're in academia, sometimes that gets in the way of doing our research, and we try very hard to get more funding so we do less and less clinic. I have been fortunate in that by doing that primary care day and a half a week, I can see when I play doctor how difficult it is to do it every day, the time, everything it takes, and how they view the world in their perspective. This became very clear to me as part of the GPCI that I needed to make what we were doing relevant. And if I could not make it relevant to the primary care pediatric day in, day out, then I was losing them as an audience. So we had to try very hard to make the importance of genetics in primary care relevant. So this is not, I'm not stealing this, and now you're videotaping me so it can go on it can be recorded, that this is not my idea. I stole this from Tracy Trotter. That one way we found to do this in GPCI is talk about what primary care physicians do well about genetics, or at least what they in fact do. So any takers on how often primary care pediatricians provide a genetic service in their practice? Any random takers? You can give an answer that's not on the list. Yes? Oh, you're just stretching. Yearly? Good answer. Okay, I say daily. And so daily because they take family histories. And so a family history is, in fact, I would contend, a genetic service. Now, they may not take the family history in the way a geneticist takes the family history, but they should at least one time during the day in seeing 20 to 40 patients take a family history or some portion thereof. That being said, there are other examples, I think, of genetic services conducted frequently in primary care pediatrics that I try to highlight when I stand there as the bridge between genetics and primary care. One, the most obvious people turn to all the time is newborn screening, mandatory testing, I'm preaching to the choir, of all newborns for inherited diseases. However, I would argue that that doesn't resonate exceedingly well because by the time the child gets to the primary care provider, if you get a newborn screening positive result on a patient, then you're in the thick of it potentially. But by the time a child with a result gets to you who has one, they're already sort of tucked, you're not involved necessarily, it's potentially a rare outcome in your career. But so I think there are better ones. One of these is the pre-participation sports physicals. I know there are people in the audience who have to drag their children into the doctor or to urgent care to get these forms signed. So this is something that resonates with a lot of people. These are sports physicals. These are general examinations that are often required for participation of children in organized athletics, and the children require formal recommendations for clearance. And if you look in what we are supposed to be asking and checking on that form, well, we may not check on the form, but one key thing we're supposed to be asking is family history. And we're asking for sudden death risk factors. We're asking, is there premature death in the family before the age of 50? Disability in heart, this is from the American Heart Association, disability from heart disease in a close relative. We can argue about what's close. And then specific knowledge of certain conditions. So here, front and center, something I would argue I probably do every day I'm in clinic, I do at least one sports physical. We are touching genetics here and trying to identify children at risk for a genetic condition. We may not find them, but we're certainly looking. The other is the cholesterol guidelines, the pediatric cholesterol guidelines. So, these aren't my patients, of course not. So, if you look at the cholesterol guidelines put out by the expert panel in 2011, you will see that, again, family history is front and center. You are to ask for parent, grandparent, aunt, uncle, or sibling with MI, angina, stroke, CABG, stent, angioplasty, less than 55 years in males and 65 in females. And you're also to ask about the parent's total cholesterol or known dyslipidemia profile. So we could argue about whether or not we should be doing these, what's the relevance, what's the impact. But these are guidelines coming from major professional organizations and expert panels that involve genetics and that are something that we in primary care are doing on a frequent and routine basis. Family history. I'll give you another one, a fundamental task of a pediatrician. This is one of my favorites, but is that we are involved in growth and development. When the medical students come through, growth and development, growth and development, growth and development. That's what we do here. Are you growing? Are you developing normally? And so developmental surveillance, as we know from Bright Futures and the AAP, should be a component, their recommendation, of every preventive care visit. And if you go to the AAP, the American Academy of Pediatrics, the Committee on Genetics put out this report, which is to be updated in the next year, I believe, by Dr. Moschler, that says the purpose of this report is to describe the optimal clinical genetics diagnostic evaluation to assist pediatricians. Literature supports the benefit of an expert judgment, clinical judgment by consulting clinical geneticist in the diagnostic evaluation. So again, as we look for children and assess for developmental delay, when we find one, we have to ask ourselves, we should be, I should say, asking ourselves, does genetics fit into this evaluation? Whether or not how you judge is a whole separate topic. And so the third challenge, improving PCP's knowledge and skills. And this is where the GPCI comes in. We also have done education. We've done a number of things. We had, to step back and give you some information on it, we've had 3 major pieces from the GPCI. And those are, first, a colloquium in which thought leaders came together, discussed the state of affairs of genetics in primary care, particularly in pediatrics. And from that colloquium, a number of papers were published in Pediatrics about the sentinel issues. Family history was one of them, testing was another, evaluation, the overall state of affairs, technology. The second was this project I'll talk about now, and the third was resident and trainee education. And my co-medical director, Dr. Bob Saul, was in charge of that. And from there, he's created with the team clinical modules to be used for the residents. So, as I said, this was a 3-year cooperative agreement between the AAP and HRSA. And the vision, by the way, this is a screenshot of the website. If you type in GPCI into your Google browser, it will come up. You can go right to it. It is still active, even though the grant phase has ended. The vision of GPCI was to increase primary care provider knowledge and skills in providing genetic services. And the mission was to work with PCPs to enhance a number of issues: understanding of basic genetic principles, family history, technology, ethical considerations, and health information technology. Now, the Quality Improvement Project, which was the second arm, this project that I alluded to, the goal of which was to improve the collection of family history in pediatric primary care. So the Quality Improvement Project, the goal was to start out to improve some aspect of the delivery of a genetic service in primary care. After much deliberation, it became clear that the one thing that, as I said, between the challenges that primary care providers do and that they could buy into was family history. And so family history became our point of improvement. Why family history? As I mentioned, because it's a ubiquitous tool of clinicians. It's inexpensive, non-invasive, and it's an informative screening tool in primary care. How can it be helpful? We use it for a number of things in primary care. I would contend we use it for risk assessment for specific conditions, prevention, detection, and management of disease, to inform a diagnostic evaluation, preconception counseling, maybe not in pediatrics, but it's possible, foster rapport with patients, these are a number of ways in which I think it's actively used. So an overview of this project. This was first let me say that I cannot take responsibility for the work that was done in this project. The practices and the AAP staff who ran this project were truly amazing. I'm not a quality improvement expert. I have the highest of regard for what someone who does quality improvement does, given the work that I saw go on. So this project was conducted by the Practice Improvement Network of the AAP. So the AAP has these quality improvement innovation networks called the QUIN at the AAP, and these are practices that agree to be eligible or agree to sit on a panel essentially, and then if a quality improvement project comes up, they then can apply to be part of that project. So they are across the country, excuse me, spread geographically as well as urban and rural. So this project was under the QUIN, and the goal from us, what AAP did, was provide these practice teams with strategies, tools, and resources to improve the genetic service delivery in primary care. In this case, it was family history, all surrounding family history. There was a secondary goal that was the primary. There was a secondary goal of improving the care, the delivery of care to children with heritable conditions by means of a registry. That was a secondary aim of the project, but was done as well. So the patient population, 0 to 21 years, and the practices were involved 9 to 10 months. These are the 13 teams in 11 states that were involved, serving 130,000 pediatric patients annually. The practice team from the clinic, it didn't have to be the whole clinic involved, but the team had to be 3 people, had to include a lead physician, 1 to 2 other clinicians, and a nurse or assistant staff person, which made for a nice multidisciplinary team. And in fact represented reality of how care was delivered. The front desk was just as much involved sometimes in family history collection as was the doctor, sometimes more than the doctor in the back at the end of the line, so to speak. And these practices participated in 6 months of data collection regarding those project goals. So we took some demographics on the side. You'll see all of them used an EHR. They didn't use the same one, not surprisingly. There was 1 family physician in the group, and there was a diverse range of practice type and setting, large, small, single provider. So we use the Quality Improvement Process Network. For those of you who may not be familiar with it, it is the act, plan, do, study model of a quality improvement project, and sort of small cycles of identify what's a problem, plan, do, study, not for all of family history, but for many cycles along the way in the collection. For instance, the patient, it could be anything as the papers are getting lost. So that's the problem. From that you do an act, plan, study, do around it. And each practice was encouraged to do their own as they found them. And what we provided from the AAP was mentorship and education. So from the mentorship perspective, actually, the regional collaboratives were critical. In fact, it was this RC from which we have the quote we continue to use. We had a project listserv with expert group advisors. We had one-on-one support, as I mentioned, through regional genetic collaborative mentors and monthly coaching calls with a QI advisor. So there was a backdrop of resources and advice given to these practices. There were also education, in-person learning collaboratives. We had the change packet that they could access. A change packet essentially says what your goals are, and it gives you resources about family history, different tool options that you can use and or add to and share with others. And then, as I said, ad hoc education is needed. So we had monthly data collection to evaluate it, as well as progress reports. We evaluated had asked them to evaluate the change packet. We had pre-post surveys, and then we checked for sustainability, which we're going into now, looking 6 months post. And so what did we find? So we could get them to take a more extensive family history. Again, I understand this could be the Hawthorne effect. You don't know if they're taking it because they're involved. But you did see fluctuations in the practice as well. You saw improvement with grandparents, for instance, aunts and uncles and cousins. The cousins, among the most drastic, 8 to 48%. We could have a separate discussion about the need for 3 or 4 generation family history in primary care, but I will table that for today. But they were able to take a more comprehensive family history in the case of how many people they asked about. They were able, when we gave them the family history components that we asked them to collect, they were able to meet high metrics in collecting them and make great changes in some. So I circled the top 4 here. So clotting bleeding disorder was among the highest. Sensory birth defects, carriers conditions, structural birth defects, those are among the highest. Now, truth be told, it is difficult to create a list of family history components that must be in a primary care practice family history, which was a section of debate. So this is by no means the golden tablet, let me be clear. This was our best shot at what we thought would be reasonable, having spoken with experts across the country and deliberated around tables. But it is still, to me, interesting that we don't necessarily have a clarity on exactly what should be in that family history, which I don't mean to cause a spur of debate. But it did around the AAP. Consanguinity, which is an interesting one, and I have some time to go into. Consanguinity is interesting that they went up 62% in the percent of practices that took it, because it was an example of one that caused great angst amongst the primary care providers and was very, for me, illustrative of what the issues can be. So consanguinity from a genetics perspective is like a core issue that you would ask about in a genetics clinic. I have geneticists I work with, they're like, of course you ask about consanguinity. When you talk to the primary care providers, they're like, why would I ask that? And we're like, well, you want to know if there's a consanguinity in the family, it will increase their risk. So once we explained to them the rationale why, which they knew from medical school, but we just had to reiterate, they were comfortable with it. They said, okay, we'll ask it. So they go forward and ask it. Then they would come upon the patient with a consanguineous relationship. And on the calls would be like, well, what do I do? And we say, well, that's good. There's nothing to do. Well, what do I do? Because it became clear to me, for the primary care physician, the most immediate response is, what do I do? And do for them is action for the patient's immediate care. For us, it meant, that's great. Why don't we log it in the chart? In case something happens later, it's something good to know. We should, and it sort of blew their mind. Now, granted, you would say, well, but they do preventive care. However, the preventive care is usually on something they can somewhat see or somewhat comprehend. They just couldn't comprehend it. Let alone the fact that it unearths this discussion about how you have an electronic health record that catalogs everything that you may not be able to access later. So where were they going to put it? I mean, if it were in a paper chart, it'd be right on the front or in the first page. It actually was not easy to get it into the well, it is easy to get it into the medical record. It was not easy to get it back out for anyone to remember it. So it wasn't an example of an issue that brought forth a lot of problems with how you actually use a family history once you've actually collected the information. So, did we have success? It depends on how you look at success. Dr. Rink, who's the quality improvement expert on the team, was always like, look, he was the champion and he's the glass half full. Look at how much better they've done. Look at how hard they've been working. I'm somewhere in the middle, leaning towards skepticism. I was looking for, I knew we wouldn't get them, but like, what are the hard outcomes? And to put what the HRSA said, the HRSA suggested slide said, did we make anyone better? I can't tell you we did. Hopefully we did. We improved a process of care. Hopefully we had a downstream effect on clinical outcomes. Hard to say. We're, as I said, in the stage and frame of sustainability. 6 months post will be March. Will begin in March. So we're in the middle of it right now. We're doing qualitative interviews via telephone, which I think will be very helpful as to what worked, what didn't work, what about family history tools, as we, sitting at the table, the expert panel, thought, this is a great family history tool, and then we gave to them, and they were like, no, it doesn't work. So what are the lessons learned in trying to make this bridge between the primary care provider and the geneticist as a result of this project? So I came up with 3. I'm sure there are others that others have learned. Know what's important to your bridge partner. As I mentioned and alluded to earlier, the patients were what was important. There was clear buy-in because they were part of the Quinn project. So these were activated projects, no doubt. These are change agent types, early adopters. They're interested in doing something, doing the right thing, doing what's best for the patient. So they were motivated. But you could see there was a bit of lukewarm about family history. And I will tell you this, it was not easy to recruit these patients. We were like, excellent genetics, we put it out there, and this may make you sad. But it was difficult to get patients, and in fact, we had to back off the genetics overview and make it much more about complex disease, common complex, because the more we made it seem like it was going to be about rare disease, the more the pediatric practices backed away, seemingly, or didn't come into the Quinn project. I'm not saying that's right, I'm just saying that that's was a reality we faced. So once a practice had an example where they found a patient, either a mother who had multiple miscarriages, or a patient who had a family member and then and they noticed that there might be a genetic illness running in the family, they were like the converted. They had gone to the other side. And I was like, well, it's not really data, it's anecdote. But for them, it worked. That's what they would discuss in the meetings when we came back. Well, I had a patient, and they would stand up and tell you exactly how, they said to us, I would never have done this before this project. I would never have taken that extensive a family history. I would have said, anything new in the family? No? Okay. And I would have gone on. But because of that, they found a patient, and they moved forward, and they felt like they'd helped the patient. And it was clear that they became the converted. The other was understand your bridge partner's barriers. This was when we were in our perfect zone of, we're going to have you collect all of this family history data as if you have an hour-long visit with the patient, and that was just not going to happen. We had to deal with the patients coming in for a 10 to 15-minute visit. And to some degree, relaxed our expectation of the process that maybe we can do a family history that's iterative of sorts, that it builds on itself, that we have to acknowledge that we might not get 3 generations and everything on the checklist in the 15-minute visit in which we're talking about tantrums and sleep problems and wetting the bed. So we worked with the practices, understanding that to be so, and in fact, out of this, again with funding from HRSA, developed the Pediatric Family History Tool, which was adapted and adopted from the prenatal tool, and is available, not only in PC form though, but is available to both help the clinician take the family history by leveraging it, or by, I should say, delegating it to the family off of a pad. Some of the practices put it on a web-based portal, and then alerting the provider to the fact that there may be some risk, elevated risk, running in that child's family. There, to our knowledge, is no other pediatric family history risk tool that exists. If you know of one, please tell me. And lesson 3, relationships matter. And this is where I'll give you the anecdote that came from your region. So we were at our second collaborative learning session, and one of the providers stood up. She was from a small practice in Alabama, two physicians. She was the only one who cared about genetics. And there were 2 practices she would shuttle back and forth to. I think maybe there was a total of 3 docs between them. And she said, before this project came to be, I had no idea what a genetic counselor was. And now, I forgot the genetic counselor's name, forgive me, Sylvia is on my speed dial. And then she was like, Sylvia, where are you? And then they waved to each other. So she literally had no idea what a genetic counselor was. She then said that she probably called her, she said initially I would call her very frequently in the project, maybe once, a few times a week. And then as I got more comfortable and I learned from her, then I would call her less. Maybe I call her once a month with a problem. And so for us, that was a wonderful thing. not to be sappy, but because we were able to utilize the regional collaboratives, have the providers learn that they have a friend that doesn't have to be a geneticist. Not that geneticists are bad, but they're rare and they're busy. And that they can learn things from the genetic counselors and they can apply that to their practice. So that is a story that we continue to use. And so I think at least with addressing these three challenges, belief, relevance, and skill, we can make some process improvement in this goal of integrating genetics into primary care. And we may be able to get the camel, at least the head of the camel, through the eye of the needle. Thank you. Sure. Oh no. The funder.
Is that?
There it is.
Oh, okay. You missed the accolades. I was complimenting AAP and what a nice job they did. But also, I wanted to let just folk know who may not be tuned in. The IOM Roundtable on Translating Genomic-Based Research into Health meeting in August is devoted to education and how do we increase a knowledgeable workforce around using genomics? So if you are in DC in that area, it's open. It's a public workshop. It's going to be looking at processes that we might want to think about, and then also at different stages of medical training, both the residency training and then continuing education and some of the particular problems in both of those
When
areas.
is it?
It is August.
This year.
Yes.
Okay.
Yeah.
I'll be on my honeymoon.
Yeah, and there will be a write-up afterwards, but it's Monday and Tuesday, August. Fill in August something.
Oh, I'm supposed to fill in?
N- August.
We'll find it and Ronnie
I'll
can
find it.
announce it. Oh, no, just finance.